Welcome to the webinar, Understanding the Many Faces of Gambling-Related Problems, Origins, Identification, and Treatment, a webinar for health providers. My name is Vanessa Graham, and I am Administrative Research Coordinator at the Division on Addiction at Cambridge Health Alliance. This event is funded by the Massachusetts Department of Public Health, Bureau of Substance Addiction Services, and directed by the Division on Addiction, Cambridge Health Alliance, a Harvard Medical School teaching hospital. This activity is designed to prepare mental health and substance use treatment providers to recognize and manage gambling-related problems in their clients and includes a discussion of the Massachusetts Department of Public Health's practice guidelines for treating gambling-related problems and evidence-based treatment guide for clinicians. Continuing education credit agencies for this webinar include the American Psychological Association, American Academy of Healthcare Providers in the Addictive Disorders, National Association of Alcoholism and Drug Abuse Counselors, National Board of Certified Counselors, and the Massachusetts Board of Registration in Nursing. To receive these continuing education credits, you must be registered for this webinar and complete the evaluation survey at the end of the webinar. Additionally, a link to the survey will be emailed to registered attendees shortly after the webinar concludes. Once you have completed the survey, you will receive your certificate of CEU credits within 5 business days via the email address you provided at registration. If you have any questions with the survey, email vgraham@challiance.org. The Division on Addiction currently receives funding from DraftKings Incorporated, the Massachusetts Department of Public Health, Bureau of Substance Addiction Services, Massachusetts Gaming Commission of the Commonwealth of Massachusetts, the Foundation for Advancing Alcohol Responsibility, the Indian Health Service with funds approved by National Institute of General Medical Sciences, National Institutes of Health, MGM Resorts International, and the Tunghua Group of Hospitals. This webinar has 3 sections. First, Dr. Heather Gray will describe how gambling can be an addiction using the syndrome model of addiction as her framework. Dr. Gray is Associate Director of Academic Affairs at the Division on Addiction and an instructor in psychiatry at Harvard Medical School. Dr. Gray joined the division during 2008. With her Division on Addiction colleagues, she studies the development of and recovery from addictive disorders, including gambling disorder, with a particular interest in social determinants of health. Dr. Gray also serves as the editor of The Basis, the brief addiction science information source. In part 2 of the webinar, Dr. Sarah Nelson will present the etiology and epidemiology of gambling-related problems and identifying gambling-related problems. Dr. Nelson is the Associate Director for Research at the Division on Addiction, Cambridge Health Alliance, and is an Assistant Professor of Psychiatry at Harvard Medical School. At the division, Dr. Nelson is pursuing 4 major lines of research: studying the etiology of addiction, evaluating voluntary gambling interventions such as self-exclusion, determining the needs of Native youth in their communities around addiction and recovery, and investigating the relationships between DUI offense, psychiatric comorbidity, and other psychosocial factors. Dr. Nelson has collaborated on studies of gambling. Recently, Dr. Nelson and others at the Division on Addiction have extended that work to examine the actual play patterns of subscribers to a daily fantasy sports provider. The final segment of the webinar covers treating gambling-related problems, other clinical and training resources in Massachusetts, and concluding thoughts presented by Dr. Debbie LaPlante. Dr. LaPlante is Director of Research and Academic Affairs at the Division on Addiction, Cambridge Health Alliance, and an Assistant Professor of Psychiatry at Harvard Medical School. She joined the division during 2001 and has been involved with its diverse research, education, and outreach activities. With her colleagues, she developed the syndrome model of addiction. For Massachusetts, Dr. LaPlante is overseeing the division's evaluations of the Massachusetts Gaming Commission's voluntary self-exclusion, Game Sense, and Play My Way programs. She also is working with the Department of Public Health's Office for Problem Gambling Services to complete a gap analysis of gambling treatment services in the Commonwealth. If you have any questions during the webinar, feel free to submit them during the presentation on the webinar dashboard. We will use any remaining time at the end to answer your questions. This webinar has 4 major learning objectives. By the end of the webinar, you will be able to apply the addiction syndrome model and its treatment implications to gambling-related problems. You will be able to develop strategies to screen clients for gambling disorder, understand and apply evidence-based practices in management of gambling disorder, and refer clients to self-help and professional treatment resources for gambling-related problems. At this time, I will turn things over to Dr. Gray.
Thanks, Vanessa. Here's something you probably didn't expect to see next. It's an example of a typical spider web spun by a spider that was used in an experiment by a German researcher named Dr. Witt in the 1950s. Dr. Witt gave flies different kinds of drugs, and then he fed those flies to spiders. He wanted to see how consuming these drugs changed the spider's ability to spin webs. There were 4 types of drugs: hashish, LSD, caffeine, and mescaline, and 4 resulting spider webs. Can you match the drug to the web? Take a minute and try to write down your answers if you can. Okay, it's time for our first poll of the webinar. Did you think that web C was spun by a spider dosed with LSD? Answer yes or no. Give you about 10 more seconds. Okay, great, thank you. So looks like we had a pretty even split. About 47% of you answered yes, which is what I did the first time I saw this. And the majority, 53%, answered no. And here are the answers. So those of you who said no were right. Actually, web C was spun by the spider dosed with caffeine. And it was web B that was spun by the spider dosed with LSD. So I like to show this experiment for a couple of reasons. First, because for most of us, it reveals quite a bit about our assumptions about drugs and their effects. Many people do think that web C was spun by the spider dosed with LSD. And this illustrates that we have assumptions about the effects of drugs that can turn out to be wrong. When learning any new skill, it's important to recognize that we often hold assumptions that turn out to be wrong, and we need to be willing to challenge those assumptions. And second, this experiment reveals that the way a government treats certain activities influences our beliefs about those activities. I bet that many of us think that LSD is more disruptive than caffeine, at least partly because taking LSD is illegal. In the same way, the manner in which a government regulates gambling activities influences our perception about the dangerousness of those activities. Now I'm going to move from spiders to surveys. I'm going to talk about one of the world's largest mental health epidemiological surveys from the World Health Organization's World Mental Health Survey, and that was in the field from 2006 to 2012. The sample size for the results I'll show you is over 31,000 people from many different countries. And the participants answered questions about their lifetime experience of alcohol use disorder as defined by the DSM-5, among other conditions. So with regard to alcohol use disorder, here's what the researchers found. 23% of the sample reported that they had never used alcohol in their lifetimes. Just about 60% of the sample reported that they had used alcohol in their lifetimes, but they had never experienced any of the symptoms of alcohol use disorder. 6.5% had used alcohol and had experienced one criterion, but would not be said to have experienced alcohol use disorder. 7.9% had mild or moderate alcohol use disorder in their lifetimes because they endorsed between 2 and 5 criteria. And finally, 2.8% had experienced at some point severe alcohol use disorder. They endorsed 6 or more criteria. People with alcohol use disorder experience lasting harm, and so do their loved ones. But in order to help those people and prevent new cases of alcohol use disorder, we need to understand the nature of addiction, and that starts by recognizing that most people who drink alcohol don't experience negative consequences. In the same way, most people who gamble don't develop gambling disorder. In other words, things do not cause addiction. Instead, the development of addiction depends upon the interaction among our bodies, our minds, our experiences, our social settings, and properties of the potential object of addiction. Once you think of addiction as a relationship between a person and the object of addiction, and not simply the result of a substance with certain chemical properties, it becomes easier to understand how a person can become addicted to a behavior like gambling. This integrated view of addiction is central to the syndrome model of addiction. Before describing the syndrome model, I'll take just a minute to tell you more about gambling and provide a formal definition. In 1999, David Korn and Howard Schaefer defined gambling as risking something of value on the outcome of an event when the probability of winning is less than certain. Now, many people hold an overly narrow view of gambling. They don't think of certain kinds of gambling, like a charity casino night or charity raffle, as gambling, when in fact they are, because the person is risking something of value on an outcome when the probability of winning is less than certain. And this again goes back to the point I made earlier, that the way that government regulates gambling can influence our perception of risk and danger. So now on to the syndrome model of addiction. This model was first advanced in 2004 in a paper published in the Harvard Review of Psychiatry by my colleagues, led by Howard Schaefer, Debbie LaPlante, and Richard Labrie. And here are its central tenets. First, the objects of addiction play a less central role in the development of addiction than previously thought. Evidence of shared psychosocial antecedents, manifestations, and sequelae, or consequences, reflect an underlying addiction syndrome. Addiction should be understood as a syndrome with multiple opportunistic infections. A syndrome is simply a cluster of symptoms and signs related to an abnormal underlying condition. And not all symptoms or signs are present in every expression of the syndrome. And some manifestations of a syndrome have unique signs and symptoms. A useful analogy is to the early days of the AIDS epidemic, when some people presented with lung infections, others presented with lymphomas and other cancers. And at the beginning, these rare diseases were not yet recognized as opportunistic infections of an underlying immune deficiency syndrome. Now I'll describe the syndrome model in more detail. I'm going to go through these three panels, starting on the left-hand side, where we have distal antecedents of the addiction syndrome. These might include neurobiological elements, such as genetic risk or neurobiological system risk, as well as psychosocial elements, such as pre-existing mental health conditions, delinquency, poverty, and risky peer groups. These two combine to produce an underlying vulnerability. Over their lifetimes, people have access to and experience with different potential objects of addiction, whether it be alcohol, cigarettes, gambling, or something else. Interacting with such objects can expose at-risk individuals to neurobiological consequences that are common to all objects of addiction, such as the activation of the brain's reward system. So you need to have exposure and interactions. I might have all the vulnerability in the world, but if I never encounter drugs, alcohol, gambling, or other potential objects of addiction, I won't develop addiction. If the potential object of addiction produces immediate neurobiological consequences that result in a desirable subjective shift, in other words, if it makes the person feel good and can be expected to do that reliably, and that person is already vulnerable, the stage is set for addiction. Moving on now to the premorbid addiction syndrome phase. When an individual engages in repeated interactions with a specific object of addiction and experiences that desirable subjective shift, then that person might be considered to be in a premorbid addiction stage. A person might teeter on a delicate balance that can shift him or her toward a more or less healthy relationship with that substance or activity. Now let's move on to the right-hand side of the panel. Here's where we start to see manifestations and sequelae of addiction, some unique and some shared. So for instance, you can see some unique manifestations and sequelae at the top here. Drinking is more likely to produce liver cirrhosis than gambling debt, of course. Gambling is more likely to produce gambling debt than lung cancer, and so on. These consequences are what comes to mind often when we think about these expressions of addiction as distinct disorders. But we also need to keep in mind that there are many shared manifestations and sequelae. So for instance, in the biological cluster, both people with substance use disorders and people with gambling disorder experience the biological hallmarks of addiction, and those are tolerance and withdrawal. In the next section, I'm going to briefly review evidence supporting the syndrome model, which includes several of these shared manifestations and sequelae. This evidence comes from 5 domains: shared subjective experience, shared neurobiological basis, genetic overlap, shared psychosocial antecedents, and treatment non-specificity. Starting with shared subjective experience. There are many observed similarities between behavioral and substance addictions when it comes to subjective experience. People report repetitive or compulsive behavior despite adverse consequences, diminished control over the problematic behavior, a state of anticipated pleasure prior to engaging in the problematic behavior, a positive and satisfying feeling while engaging in the problematic behavior, tolerance and withdrawal, as I mentioned earlier. Attempts to cut back or stop are often unsuccessful, and symptoms often emerge during the critical phase of adolescence and young adulthood. Here's an example to illustrate. Imagine someone who's experienced gambling disorder and someone who's experiencing alcohol use disorder. The person with gambling disorder might accumulate overwhelming gambling debt and might even engage in illegal acts to fund his or her gambling. And the person with alcohol use disorder might experience liver disease or alcohol poisoning. So these are some unique consequences, but there are many shared consequences. And these are the aspects of subjective experience that I mentioned earlier, such as engaging in repetitive or compulsive behavior and feeling diminished control. So I hope that if you are, as a provider, comfortable treating people with substance use disorders, this information might give you some more confidence treating people with gambling disorder, learning more about how the subjective experience is so similar across conditions. Moving on now to comparable neurobiological effects. When we talk about the neurobiological effects of addiction, we're usually talking about the brain's reward system. And these effects are consistent across expressions of addiction. So for instance, we know that even a single exposure to nicotine can change activity in the dopaminergic reward system in a way that increases risk for addiction. But you might not also have known that studies have shown that when people with gambling disorder view videos of gambling, their brains look pretty similar to the brains of people addicted to cocaine when they see cocaine imagery. And this comes from several studies by Dr. Mark Potenza and others. Research on rats shows that eating Oreos activates more neurons in the brain's reward system than even exposure to drugs of abuse like cocaine or morphine. What else activates the dopamine-associated reward system? Well, infant faces do when they're viewed by their mothers, not necessarily when viewed by other mothers. And of course, it's adaptive for our species if mothers derive pleasure from looking at their infants' faces. So this is how the reward system is supposed to work, and unfortunately it gets hijacked when people are experiencing addiction, whether it be substance use disorder or gambling disorder. The third area of research concerns genetic overlap. In a study of male twins, Kendler and his colleagues in 2003 could not find evidence for genetic factors that increased risk for individuals to abuse substance A and not also to abuse substance B, C, and D. So this indicates that genetic risk is not specific, but it's more general across substances. And then more recently, Wendy Slutsky and her colleagues in a study of male and female twins found that 1/2 to 2/3 of the association between gambling disorder and alcohol use disorder was due to a shared genetic vulnerability. Now for shared psychosocial antecedents. I alluded to these earlier, and Dr. Sarah Nelson will describe them in a bit more detail later on. But just briefly, people with many different expressions of addiction often report they experience psychiatric conditions like depression or anxiety, and often report that they experienced them before developing addiction. Other shared psychosocial antecedents include trauma, impulsivity or poor self-regulation, delinquency or trouble with authority, lack of social support, and certain socioeconomic characteristics like poverty. And finally, there's some evidence of treatment non-specificity. We know in terms of pharmacological treatments that some treatments or medications that were originally used for one expression of addiction seem to be useful for others. And examples of those include naltrexone for gambling or methadone for cocaine. And there are some non-pharmacological treatments that seem to be effective across expressions of addiction. And Dr. LaPlante will describe these in more detail, but just briefly, they include cognitive behavioral therapy, self-help, brief screening, and motivational interviewing. The latest version of the DSM reflects this view of addiction. So in DSM-4, gambling disorder was listed separately from substance use disorders, and now it's listed alongside them in a new category called substance-related and addictive disorders. Internet gaming disorder is currently listed as a condition for which more research is needed. And you might have heard that earlier this month, the World Health Organization added gaming disorder to its compendium of medical conditions, the ICD. Before I wrap up, I'll present some implications of the syndrome model for treatment. So first, the question of whether addictions are always progressive. Are they always a downward cycle once a person starts to develop addiction? And the answer to that is no, not if we no longer define addiction as a property of an object. If you change a person, then you can change that person's relationship with an object of addiction. Remember the premorbid addiction stage that I mentioned earlier, and that can be a useful time to change a person's object or relationship with an object of addiction, sometimes even through a screen or brief intervention. It's important to consider the recursive nature of syndromes. And applied to addiction, that means that experiencing one expression of addiction can create risk factors for additional experiences of addiction. So for instance, a person might experience many psychosocial risk factors early in life that predispose him to experience gambling disorder. And you can imagine how that gambling disorder would impact his life and fracture relationships. Even if he recovers from gambling disorder, those fractured relationships can contribute to additional psychosocial risk factors that can make him vulnerable to another experience of addiction later on. And so this might encourage you as providers to try to learn as much as you can about the role of personal relationships in a client's addiction history. And finally, treating addiction as a syndrome suggests that it is multidimensional. We need to address other mental and physical health conditions which would otherwise complicate treatment. And as a provider, you might want to try to determine the relationship between a mental or physical health condition and addiction. For instance, did your client's depression occur as a cause or a consequence of gambling disorder? A cocktail approach is likely to be most effective. For instance, with gambling disorder, a person might benefit most from a combination of CBT, pharmacotherapy, financial counseling, and family therapy. With that, I'll turn it over to Dr. Sarah Nelson.
Thank you, Heather, and thank you all for attending our webinar today. In this section, I will be speaking a little bit about the etiology of gambling-related problems, including the effect of exposure, individual trajectories of problems, and psychiatric comorbidity. I'll then review how we identify and assess gambling-related problems. As Dr. Gray has explained, to understand gambling-related problems, we need to step back and consider how gambling disorder fits within our greater understanding of addiction. The syndrome view of addiction Dr. Gray presented indicates that traditional objects of addiction, like alcohol or cigarettes, might be less central to addiction than previously thought. One way to examine this is through the investigation of exposure effects. As Dr. Gray pointed out in the syndrome model, exposure plays a role in addiction. What happens when individuals are newly exposed to an object of addiction? Applied to gambling, what happens when individuals are newly exposed to opportunities to gamble? Let's take a quick poll. What do you think will happen when individuals are newly exposed to opportunities to gamble? Will problems increase as a result? Will they increase at the same rate as time goes on? Please go ahead and record your answer now. Okay, I'll give you about 10 more seconds. Okay, so it looks like about a third of you thought that they would increase linearly across time. Close to half thought that they would increase but not linearly across time, and 12% thought that they would not increase. So let's see what we find out. The most straightforward view is that exposure ought to increase rates of problems, and that more exposure ought to lead to more problems. And some research finds such a relationship. For example, the National Gambling Impact Study Commission reported early on that having a casino within 50 miles of one's home elevates your risk for experiencing a gambling-related problem. Similarly, our own work at the Division on Addiction has demonstrated associations between the presence of gambling opportunities and helpline calls in Iowa, as well as casino self-exclusion rates in Missouri. But let's look at this from a more macro level. In the United States, the rate of serious gambling disorders was 0.7% during the middle 1970s. Today, multiple research groups estimate the rate to be about 0.6%. So the prevalence of gambling disorder has been stable during the past 35 years, despite dramatic increases in the growth of gambling exposure and access. Here we see some of the major general population studies of gambling and gambling problems that have been done in the US. The first national report on pathological gambling behavior in the United States was conducted in 1975. At that time, only a few states had state-run lotteries, and casino gambling was confined to Nevada. Clearly, there's been an increase in both government-sponsored gaming and legalized gaming since then. But as this chart shows, nationally, there has been no significant increase in gambling disorder since 1975, despite the growth of gambling and participation in gambling. These data suggest that since 1975, more people have tried gambling, but the number who develop problems has not increased to the same extent. Disordered gambling appears to be a relatively stable phenomenon across time. But the best test of the effects of gambling legalization on disordered gambling, of course, is to look at disordered gambling before and after a casino opening or lottery implementation in a given community. The Division on Addiction collaborated with Spectrum Gaming Group to produce a systematic review of this type of literature related to gambling expansion. We conducted a quantitative analysis of selected peer-reviewed and gray literature that we assessed for methodological quality, extent of gambling expansion, and extent of impact. The available peer-reviewed literature did not provide conclusive evidence of a relationship between gambling expansion and gambling-related problems. Some research suggested that expansion might instigate problems, but the majority of evidence indicated otherwise. The methodological quality of the reviewed studies was not high. Similarly, findings were mixed for the gray literature. The majority, mostly state reports, found no significant changes in gambling problems after expansion. There was some preliminary evidence that the extent of expansion related positively to gambling problem rates, but the set of studies was too small to draw any strong conclusions. There are a few plausible explanations for the lack of consistent findings across studies. One is that studies that are actually able to detect impact are rare in the gambling field. To assess impact, a study needs to be prospective, include multiple waves, and be large enough to identify a low base rate disorder. Another explanation, however, is that exposure effects are not linear. Researchers have made use of a toxin analogy to hypothesize about the effects that social events like gambling might have on the population. This has roots in McGuire's social inoculation theories, in which he argued that certain social events are the social equivalents of exposure to germs. Exposure to those events can result in something like an infection. If we conceptualize exposure to gambling as the social equivalent of exposure to germs or infection, then we can treat gambling problems as an infection. Exposure can lead to infection, but typical infection curves suggest that the process is not linear. Here's an illustration adapted from a paper on emerging infectious diseases. In this case, exposure leads to a rapid increase of infection. The infection targets the most vulnerable first. More exposure translates into a greater likelihood of infection for an increasingly large segment of the population. But then the rates slow, and people who are not yet infected or become more resistant. People recover, and incidence rates decline. This can be applied to gambling expansion. Following initial increases in adverse reactions to new environmental events, individuals in a population become resistant to those events. Potential sources of adaptation in this case include social learning, waning novelty effects, or interventions, to name a few. But what's the actual evidence? Studies in Nevada have found two trends that fit the adaptation curve. First of all, newcomers to Nevada evidence higher rates of problems than those who have lived there for more than 10 years. Second, younger and newer employees at casinos where gambling problems are elevated evidence higher rates of problems than older and longer-term employees. If we look at Dr. Bob Ladusseur's longitudinal study of casino expansion in a community in Quebec, he found that gambling problems increased from pre-test to 1-year follow-up, during which time the casino opened, but then decreased across the next 3 follow-ups, following the adaptation curve that we see on the left. Similarly, we found that in Missouri, rates of casino self-exclusion, which is a reasonable indicator of gambling problems, increased initially when more casinos were introduced, but then leveled off, again following that adaptation curve. So if we return to our poll, the correct answer is most likely that there is a relationship between exposure and problems, but that relationship is neither universal nor linear across time. Different segments of the population are affected differently, and individuals adapt in different ways to new stimuli. When studying epidemiology, we often talk about prevalence and incidence. Prevalence is the rate of a behavior or problem in a population at a given time. For example, the prevalence of gambling disorder in the US population is around 1% or less. Incidence is the rate of new occurrences of a behavior or problem. So in a given year, how many people who didn't have gambling disorder develop gambling disorder? Applied to the syndrome model, incidence would measure the proportion of individuals who move from one panel of this chart to the next. So when we think about the stability of gambling disorder, we need to be careful about what we mean. We saw that the prevalence of gambling disorder seems quite stable across time. What about symptoms of gambling problems within individuals? Let's take another quick poll. Do you think that gambling-related problems are stable across time? What about at the individual level? Once people develop problems, do the problems remain across time? Do they get worse? Go ahead and record your responses. Give you about 5 to 10 more seconds. Okay, so it looks like about half of you said that gambling-related problems are stable over time at the population level, but not the individual level. About a quarter of you said at the individual level, And about a quarter of you said that gambling-related problems always get worse over time. Let's look at this illustration. We know that the prevalence of gambling disorder has stayed relatively stable over time. However, this information tells us about the average behavior of groups, not necessarily about individual patterns. It would be easy to assume that gambling problems within individuals are stable across time, too. In this diagram, we could assume the same people fill each cell at time 1, time 2, and time 3. However, it's important to note that this seemingly stable pattern could mask major changes at the individual level. New cases could emerge and replace old cases that fall into remission. So in this case, there's stable prevalence, but the individual experience of gambling-related problems is not a stable phenomenon. The fact is, gambling disorder is not a stable phenomenon. Studies show that individuals recover and worsen across time in dynamic, fluctuating patterns. Dr. Wendy Slutsky and her team examined data from 2 US nationally representative studies that measured criteria for gambling disorders, as well as treatment seeking. About a third of the people who qualified for lifetime gambling disorder did not report past year symptoms, and reported receiving no treatment for their gambling problems, suggesting that they recovered without formal treatment. Similarly, at the division, we analyzed data from a large nationally representative general population study and found that individuals did not report the same gambling-related problems in the past year as in their lifetime, and the number of criteria they endorsed varied depending on whether they were reporting past year or prior to past year symptoms of gambling disorder. Different criteria were more stable than others. In particular, individuals who reported gambling to escape their problems were likely to continue to report that symptom as occurring within the past year, and were more likely to qualify for gambling disorder in the past year. So if we return to our poll, the correct answer is most likely that we see stability at the population level, but not at the individual level. Now I'd like to turn to how we go about identifying gambling disorders. And for this, I'd like to return to the syndrome model again. Let's start with a group of people who might qualify for gambling disorder. If we begin to assess them for other disorders beyond gambling, we might find that a subset also qualify for manic episodes. Others might suffer from depression. A large subset might experience a personality disorder, and some might have disorders that we haven't even assessed for. In the end, we're left with a minority who suffer only from gambling disorder. It might be that a more general syndrome disorder accounts for all of these symptoms. This has implications for how we identify, prevent, and treat gambling disorder. And indeed, when we look at the data, psychiatric comorbidity, in other words, suffering from multiple mental health disorders, is particularly associated with gambling disorder. The majority of individuals with gambling disorder experience other mental health and substance use disorders as well. In this study, Dr. Petrie found that more than 70% of individuals with gambling disorder also qualified for alcohol use disorder. More than 60% qualified for a personality disorder, and close to half qualified for a mood disorder. These findings held in both recent US national general population studies of psychiatric comorbidity. Now, here it is important to note that finding an association does not tell us about the causal pathways. If it did, we might find this sign a little bit troubling. We don't know from an association whether mental health or substance use issues influence the development of gambling problems or vice versa, or whether some third set of factors influences both. And research is mixed as to whether the psychiatric comorbidity is a determinant, correlate, or consequence of addiction. The syndrome model shows it as both. The self-medication hypothesis would suggest that in many cases, the development of addiction occurs when individuals attempt to use substances or activities to relieve psychological suffering. This would suggest that mental health issues would precede addiction for these individuals. But we also know that psychiatric problems, particularly depression and anxiety, can emerge as a consequence of addiction. For gambling, there is some evidence that in the majority of cases, the mental health disorder precedes the gambling disorder. In the National Comorbidity Survey replication, 74% of respondents who had gambling disorder and another comorbid disorder indicated that they experienced symptoms of the mental health or substance use disorder prior to symptoms of the gambling disorder. One of the reasons this discussion of comorbidity is important is that although we can reliably measure disordered gambling, it's sometimes uncertain what we are measuring. In some cases, disordered gambling might simply be a manifestation of another underlying problem. This is not a unique problem for gambling disorder, but applies to the assessment of many mental health disorders. Without an independent gold standard, scientists and clinicians often end up identifying a disorder by its consequences. For example, many of the DSM criteria for gambling disorder assess consequences of that disorder, such as lying to friends and family or relying on others for financial needs due to gambling, which can make prevention and prediction difficult. For gambling disorders, there are more than 30 instruments designed to measure disordered gambling, and these different tools often do not agree on whether someone has a gambling disorder. Many assessments are based on DSM criteria and usually use one or two items to measure each DSM criterion. I'm going to briefly review a few of the most common assessments. The South Oaks Gambling Screen is one of the oldest and most used and researched assessments. It includes 20 dichotomous scored items that were adapted from the DSM-3. Gamblers can be classified as non-problem, problem, or if they endorse 5 or more items, probable pathological gamblers. The assessment was developed for use as a clinical tool, and some research suggests it produces high false positive rates in general population surveys, meaning it classifies more people as having gambling disorder than other clinical measures would indicate. The Canadian Problem Gambling Index is a more recent tool and tends to produce more valid estimates of prevalence rates in the general population. It includes 31 items, 9 of which comprise the Problem Gambling Severity Index, or PGSI. The PGSI classifies gamblers as non-problem, low risk, moderate risk, or if they score 8 or higher out of a possible 27, problem gamblers. The Canadian Problem Gambling Index has good psychometric properties and performs well in multiple studies when compared to clinical diagnosis. And one of the most recent assessments to be developed is the Problem and Pathological Gambling Measure. It includes 14 dichotomous items. Unlike other measures that use basic counts and cutoff scores, the PPGM requires that individuals fulfill criteria in 2 separate domains, harm and impaired control, to qualify for gambling disorder. Gamblers can be classified as recreational, at risk, problem, or if they endorse 5 or more items and endorse both harm and impaired control items, pathological gamblers. More research is needed to determine the validity of this tool since it's so new. Honestly, the type of assessment used to measure gambling-related problems is less important than how you use it or what you do with the results. We need to think about how a given assessment is used. We know that some assessments have better validity and reliability in clinical settings than in general population settings, and vice versa. And those facts should influence what you choose. You'll remember from earlier that gambling-related problems are not stable across time. So a gambling assessment used properly can tell you what symptoms a client is experiencing, how those are changing across time, and what that might mean for recovery or relapse triggers. It's also important to note that though the difference between qualifying for gambling disorder and not qualifying might have importance in terms of research on population trends or insurance reimbursement, on the individual level, the difference between endorsing 3 and 5 criteria might be less important than the effect of those symptoms on an individual and his or her functioning and suffering. Do not ignore subclinical cases. I'd like to briefly address implications of the changes to gambling disorder from DSM-4 to DSM-5 for gambling assessments. This slide shows the criteria for gambling disorder in DSM-4. There were 10 criteria, and a client had to endorse 5 to qualify for gambling disorder. Those criteria are listed here. DSM-5 does not include committing illegal acts as a criterion, but all the other criteria remain the same. In DSM-5, a person has to endorse 4 of the 9 criteria instead of 5 out of 10 to qualify as a disordered gambler. So what are the implications of this change? Not much. Part of the reason that the illegal acts criterion was removed was that very few individuals endorsed it anyway, and those who did already endorsed enough other criteria to qualify for gambling disorder. In a study that compared the 2 sets of criteria among a sample of more than 3,700 individuals, 600 of whom qualified for gambling disorder using DSM-4, Dr. Nancy Petrie and her colleagues found that 98.3% of the sample she used was classified the same way using both the DSM-4 and the DSM-5 classification schemes. So identifying and assessing gambling disorder can be complicated and time-consuming. But how do we even get to the point of doing those assessments? One last poll. Where are you most likely to encounter people with gambling-related problems? Seeking treatment for those problems? Seeking treatment for other problems? Or not in treatment at all? Go ahead and record your answers once you've had a chance to think about them. Okay, we'll give you 10 more seconds. Great, thank you. So it looks like the majority of you thought that you were most likely to encounter people with gambling-related problems seeking treatment for other substance use or mental health problems. We will find out in the next section. In this last section, I want to cover what might be the most important practical guideline for helping people with gambling problems: screening. Unlike a gambling disorder assessment, screening for gambling disorder is quick. It is not as precise as a gambling disorder assessment, but serves as a first indication that a person might be experiencing problems or at risk for problems. So why should we screen for gambling disorder? We know that gambling disorder leads to financial, emotional, social, occupational, and physical harms. We also know that approximately 50% or more of people with gambling problems are in treatment for something, but very few are in treatment specifically for gambling-related problems. So it looks like the majority of you were correct in your answer to the last poll question. We know that many cases of gambling disorder go undetected. Screening can allow us to refer at-risk people to treatment services or further assessment. We can also target public health interventions to at-risk subpopulations if we're using screenings. And finally, screening is less cumbersome, particularly for vulnerable populations. And who should screen? Everyone. But to be more specific, remember that many people with undetected gambling problems are in treatment for something else. So substance use programs and mental health services in particular should screen. And how should you screen? The short answer is that it really doesn't matter as long as you use a consistent and validated tool. This slide lists 3 of those. Each is based on a few items from the DSM. These include the lie bet screen, which includes the lying and tolerance items from DSM, the NODS clip, which includes criteria related to loss of control, lying, and preoccupation, and the brief biosocial gambling screen, which includes items related to withdrawal, lying, and borrowing money. I'll briefly review the BBGS, which we developed at the Division on Addiction in 2010. The BBGS includes 3 items that were shown to be most predictive of disordered gambling. During the past 12 months, have you become restless, irritable, or anxious when trying to stop or cut down on gambling? During the past 12 months, have you tried to keep your family or friends from knowing how much you gamble? And during the past 12 months, did you have such financial trouble as a result of your gambling that you had to get help with living expenses from family, friends, or welfare? Endorsement of any one item is considered a positive screen. Our research indicates that 1 of 3 individuals who screen positive on the BBGS will be identified as having gambling disorder after follow-up. The BBGS has now also been evaluated by multiple research groups beyond the division. They have found it to be robust to DSM-5's diagnostic changes and to work well in both substance use and mental health service settings. Interestingly, in substance use settings, evaluation research suggested making the BBGS more specific and reducing false positives by changing the scoring to require the endorsement of 2 items. Whereas in mental health settings, the evaluation research suggested that the BBGS was too specific and might generate too many false negatives. These contrasting recommendations point to the importance of considering the purpose and intent of a screening. If you want to cast a wide net and identify everyone who might be at risk, you want to use a screener or cut points that are more sensitive and generate more positive screens. If you have limited resources that you want to allocate wisely, you might cast a net that lets fewer people through and generates positive screens for individuals who are most likely to qualify for the disorder. And now I'd like to hand it over to my colleague, Dr. Debbie LaPlante, who will discuss evidence-based practices for treating gambling disorders.
Thank you, Sarah. I'll start with a review of evidence-based practices, what they are, and how providers might use them. I'm sure that you have all heard the term evidence-based practices, but you might not have had the time or resources to look into what the term represents. Most simply, the primary goal of evidence-based practices is to infuse clinical work with the best scientific research, thereby guiding practice and training. There are 5 core features of evidence-based practices. First, they actually rest upon 3 pillars. Although a common misconception is that evidence-based practices are entirely focused upon research, in fact, they actually rely upon research, clinician expertise, and patient characteristics. Second, it isn't enough to be aware of these sources of information. Rather, the successful use of evidence-based practices involves the integration of these sources. Third, research provides the fundament for the successful application of practices, but fourth, patients hold an active position in the direction of their care. Fifth and finally, evidence-based practices require that treatment professionals guide the integration of these sources and work with patients as collaborators towards success. So to illustrate, in the application of evidence-based practices, one must balance the best available research that is clinically relevant, accurate, unbiased, and appropriate to the highest standard, with clinical expertise, taking advantage of past experience and training, with patient needs, including aspects such as personality and cultural differences and involvement in decision-making. In practice, Experts have recommended this mnemonic to help providers in the process of administering evidence-based practices, called AAA-TIE. Specifically, this shorthand suggests that in a particular clinical encounter, providers should ask a specific clinical question, access the best research available on the topic, appraise the research in a critical way, translate the research into action in the clinical encounter, while at the same time integrating both clinician and patient concerns. The encounter, of course, should end in evaluating the effectiveness of the plan and continue iteratively until the desired clinical outcome is achieved. Now, as you heard from Vanessa at the start of this webinar, I'm not a clinician, so for the remainder of my presentation, I'm going to focus upon one of the three pillars, the best available research. More than 15 years ago, our colleague Dr. Howard Schaefer and his colleague, the physician, Dr. David Korn, developed the first ever treatment guidelines for gambling. They used an authority-based approach to writing the guidelines that blended their clinical opinion with research. Today, we've taken a different approach so that the revised guidelines I'll describe today are empirically objective. The revised guidelines build from the original work of Schaefer and Korn and emerge directly from the latest research related to treating gambling-related problems. Let's talk about the evidence base that we're working from for these guidelines. To do that, I'd like to start with a quick poll. For gambling, about how many clinical trials of treatment approaches do you think are published per year? In a sense, this question is asking how much breadth does the clinical scientific literature actually have? We actually asked ourselves this question before we began the process of revising the Schaefer and Korn guidelines. We knew that we'd be relying upon clinical trials to build our revised guidelines, but weren't sure about how many that would include. About how many clinical trials related to gambling are published each year? 0 to 1, 2 to 5, 6 to 10, 11 or more? Give you about 10 seconds more. Okay, thank you. As you can see, almost half of you suggested that about 2 to 5 clinical trials are published each year. This graph shows recent publication trends related to gambling. The blue line at the top provides a simplistic count of the citations available by year in PsycInfo for the search term gambling. The red line indicates the count of citations available by year for the search terms gambling and treatment. As you can see, although gambling citations are increasingly substantially over year, the increases for publications that focus upon treatment are modest. The green line at the bottom represents the number of annual publications by year when we also added the word trial. So you can see that the available literature that included trials gambling treatment is quite small. About 10 years ago, a trend of roughly 10 papers that might be trials per year started, with the most in a single year being 26 publications that might include pertinent trials. For the revised guidelines themselves, we used a multifaceted search strategy, including multiple databases of different kinds and journal searches, as well as a diversity of possible search terms. The previous graph was for relatively simple search, but in order to cast the widest net possible for clinical research involving gambling, we looked for papers that included any of the terms including gambling, gambling disorder, problem gambling, pathological gambling, betting, gaming, gambling addiction, wagering, disorder gambling, gambling problems, ludomania, compulsive gambling, and gambling mania, and treatment, intervention, counseling, therapy, self-help, relapse prevention, management, mutual help, and 12-step. This strategy resulted in 7,380 published papers. From there, we narrowed in on the papers that would be appropriate to include by identifying papers that were published in English and peer reviewed. In combing through these studies, we determined that 6,599 were irrelevant by title alone. Another 639 were excluded for other reasons, such as not including another directed treatment or not actually being a primary treatment study. Instead, for example, providing a discussion or opinion about a particular treatment. In the end, we settled upon 132 clinical research papers as our eligible group of studies for detailed review, critical analysis, and treatment quality and type categorization. For those who are more visually oriented, here's a chart of how we progressed to our final set of 132 papers through successive approximations. Exclusions included publications that weren't peer-reviewed, duplicates, irrelevant topics, non-English publications, letters to editors or posters, and papers that had primary concerns related to fellowships or entirely self-directed intervention approaches. In our detailed review of the 132 studies, we considered again the type of treatment involved, such as whether they were fellowships, self-directed, or other care, the nature of treatment, the design of the study that the research used, such as whether it was a randomized clinical trial or some other design, the types of control conditions applied, and the clinical outcomes reported. We identified 3 primary levels of empirical evidence. The first we call high quality. High quality refers to treatment types that have available evidence, at least 2 well-designed randomized clinical trials from different sources that show clinically meaningful improvements related to gambling. Developing evidence, in contrast, refers to those treatment types that only have a single clinical trial available. Finally, limited evidence refers to those treatments that have been the subject of study, but with the most preliminary approaches, including case studies, pre-post design, and the like. Last poll of the day. Knowing what you know about how many papers are available, what's your guess about how many treatment types can be categorized as having high quality evidence for treating gambling-related problems? Would you answer 0 to 1, 2 to 5, 6 to 10, or 11 or more? I'll give you a minute to enter your answers. About 10 more seconds. Thank you. As you can see here, almost 60% of you said that about 2 to 5 treatments for gambling can be labeled as having high quality empirical evidence. Okay, there currently are 4 treatment types that we can label as having high quality empirical evidence. You've probably heard of them. They're cognitive behavioral therapy, CBT, motivational enhancement or interviewing, guided self-help interventions, and personalized feedback interventions. Next, I'll review what we observed about the science available for each of these types. As you might have guessed, the most frequently studied treatment type is CBT. Very briefly, this treatment type attempts to change thoughts and behaviors that maintain disordered behavior, in this case, gambling. For gambling, CBT will include correcting for issues like the illusion of control and offers insights into game mechanics, odds, and probability. In addition, CBT for gambling often will include problem-solving skills, social skills, and relapse prevention. Validated manualized approaches, including Dr. Bob Ludusser's Overcoming Pathological Gambling, are available for those who want to learn more about CBT for gambling. Another treatment with high-quality empirical evidence also will be familiar to many of you, motivational interviewing, or brief therapeutic strategies that are designed to lower resistance and enhance motivation to change. There have been a number of studies of motivational interviewing for gambling. Notably, some studies of a single session of motivational interviewing for gambling demonstrated favorable clinical outcomes extending as long as 12 months. More research with longer follow-up periods is necessary to determine how long the benefits might extend. Guided self-help also shows considerable promise. These types of interventions usually involve a workbook of some kind that people can complete on their own with the advice of a professional, in person or remotely. There have been a few trials of different tools for guided self-help, and they all show promise. One of the most well-studied of these options is Dr. David Hodgen's Becoming a Winner, Defeating Problem Gambling, a gambling self-help manual. Trials of this tool suggest that the addition of professional guidance further enhances the clinical benefits of the tool itself. Another self-help tool that we developed right here in Massachusetts and recently revised is the Your First Step to Change series. You can find Your First Step to Change on our website at the above address. Your First Step to Change has 3 primary sections. The first section, Facts About Gambling, includes activities such as the BBGS that Sarah just described, and facts and myths related to gambling-related problems. The second section, Understanding Your Gambling, provides a larger battery of screens for topics like financial consequences people might experience, co-occurring conditions like depression and anxiety, and also includes discrepancy development exercises that get people to identify and compare their ideal and actual experiences and how gambling might affect them. The third section, Thinking About Change, provides more exercises to stimulate self-reflection and also tips, tactics, and strategies for facilitating change among those who seek it. Our evaluation of Your First Step included 2 randomized clinical trials, one here in Boston and one in Las Vegas, with our partners at UNLV. We observed improvements on a variety of gambling outcomes for all of our study groups, including the control groups. However, the work group conditions were superior to the controls in promoting abstinence from gambling. The study showed that user satisfaction with Your First Step to Change is quite high. And anecdotal evidence from clinicians in Massachusetts who tell us they use it with their clients suggests the same. Finally, personalized feedback interventions have associated with them a number of successful trials. This treatment approach, first developed for drinking, compares individuals' behaviors and habits with known norms. This can be done independently or with the guidance of professionals. Trials of professional guided personalized feedback interventions, specifically the checkyourgambling.net tool, suggest that this technique is useful for helping people reduce gambling and the experience of gambling-related symptoms. In addition to these treatments that have high-quality empirical evidence, there are a number of promising treatment types that are on the verge of categorization as evidence-based practices. These include relapse prevention, brief advice, medications of various sorts, behavioral therapy, and cognitive therapy. These treatment types, even those well-tested in other areas of addiction, have no more than a single trial for gambling, or trials only tested by one source, which is why for gambling, they're listed as having developing evidence. Lastly, the number of treatment types that clinical researchers have considered is quite broad. In fact, there are probably more studies and treatment types in the limited category than either of the others. These include other medications, acceptance and commitment therapy, eye movement desensitization and reprocessing therapy, mindfulness, hypnosis, meditation, inpatient treatment, and deep transcranial magnetic stimulation. However, these treatment types do not have sufficient empirical evidence to be recommended or considered evidence-based practices. Their current quality of evidence is distinctly different. In the future, they might prove fruitful. However, they currently are not adequately supported for gambling in the scientific literature. As I alluded to earlier, the 2017 guidelines are currently available online. This allows us to update the guidelines as treatment studies are released. No more will guidelines sit on a shelf out of date as soon as the next publication is released. The revised practice guidelines are available on the Massachusetts Department of Public Health website. This is the link you will need to access them, and this is a screenshot of the homepage, so you know what it looks like when you get there. I'll leave this up for a minute so that you can copy down the website address. But if you don't finish on time, please feel free to email us at info@divisiononaddiction.org, and we can get you connected. There are a bunch of website features that are worth exploring beyond the categorization of treatment types into strength of evidence group. A section called Defining Problem Gambling includes definitions, videos, and other important content that can help clinicians understand gambling disorder, what it might cause people to experience, and who might be at risk for developing it. This image provides a snapshot of that section of the website. A section called Identifying Gambling Disorder includes access to discussions of brief screens, assessments, and DSM-5, as well as links to the Brief Addiction Science Information Source, or the BASIS, review articles related to those resources, and hyperlinks to source material. This image provides a snapshot of that section of the website. A section called Background on Evidence-Based Guidelines explains the general purpose of the guidelines and the rationale for the approach. For those who are interested in the gritty details, this section also provides methodological specifics for the way that we created the guidelines. A section called Treatment Recommendations for Gambling Disorders provides the main content for the revised evidence-based practice guidelines. This section details each of the high-quality evidence approaches, briefly defining them and describing related evidence. It also includes basis links to some related papers. These links will allow readers to read simple research summaries of supporting papers. This section of the website also reviews developing evidence treatment approaches and those with limited evidence. Finally, a section called General Information on Treatment of Gambling Disorder provides a general discussion of key clinical concepts that providers might want to review as they commence their treatment of gambling disorder. We wanted to point out a few more resources that providers might find valuable if they need to work with clients who are struggling with gambling-related problems. First, Massachusetts supports an initiative called Voluntary Self-Exclusion, or VSE. This program allows people to voluntarily exclude themselves from the gaming floor of all Massachusetts casinos. Strategy 2.4 of the Responsible Gambling Framework specifies that operators will make available to patrons 3 opportunities for VSE: removal of patrons from marketing lists, preventing the patrons from using check cashing or house credits, and voluntary self-exclusion from casinos statewide. The framework dictates that the primary location for VSE programs will take place in responsible gambling information centers, formerly branded as GameSense Info Centers. Introductory enrollment terms are 6 months, 12 months, 36 months, or 60 months. To complete enrollment, individuals must present a government-issued photo ID, complete an enrollment application, and meet with qualified VSE agent. Enrollment initiates protocols that result in the forfeiture of casino rewards points and removal from casino direct marketing mailing lists. People who violate their VSE contract are escorted from the gaming floor of the establishment when detected and forfeit any money wagered, won, or lost, including money converted to wagering instruments such as chips. Individuals who are enrolled are allowed to be in non-gambling areas of the establishment, such as restaurants. After a patron's initial VSE period, if they wish to renew their VSE contract, they can select from the same 1, 3, or 5-year terms, or select to be self-excluded for their lifetime. The Massachusetts VSE contract covers all Massachusetts casino properties, so those who currently are enrolled at Plainridge Park Casino also will be restricted from MGM Springfield and Encore Boston Harbor when these properties open. At any time after an individual's VSE period has expired, they can request that their name be removed from the VSE list. To finalize their removal from the list, the individual must complete an exit interview with an MGC, Mass Gaming Commission, designated agent. Another resource that providers who might be new to gambling treatment should know about is the Massachusetts Council on Compulsive Gambling, who currently are contracted with the Department of Public Health to provide capacity building for gambling treatment in Massachusetts. The Mass Council also operates the state's gambling helpline, which is 1-800-426-1234, and the state's casino-located GameSense Info Centers, at which people can self-exclude from gambling. Likewise, providers should be aware that the Commonwealth now has an Office of Problem Gambling Services at the Bureau of Substance Addiction Services. For additional information, about the latest science related to gambling and other expressions of addiction, providers might want to subscribe to the free science blog, the Brief Addiction Science Information Source, or the BASIS. This resource provides easy-to-read brief summaries of the latest addiction science. This month, for Pride Month, we're doing a special series that reviews addiction in the LGBTQ community. Finally, because gambling disorder is a relatively low base rate problem, many providers will have had very limited real exposure to these issues. Therefore, it might be useful to read some cases of actual experiences of people who struggle with gambling-related problems. Providers can find these at the division's website called Expressions of Addiction. We have just a few concluding thoughts for this section of the webinar. First, I would suggest that treatment guidelines can help providers select the best tools for the clinical situation that they're in. With respect to the guidelines and the treatments highlighted in the revised guidelines, that doesn't mean that other strategies won't work. Rather, it just means that there isn't any empirical evidence for those strategies yet, even if there is meaningful clinical evidence of successes for a particular technique. In adopting evidence-based practices, this needs to be kept at the forefront, as well as the need to account for both clinician and patient concerns. Next, there remains quite a large need for clinical research related to gambling. There are a few papers that are of high enough quality to support strong advocacy for particular treatment types. So researchers and practitioners should seek out more opportunities to collaborate. If anyone's interested in such collaboration with the division, please do not hesitate to let us know. Of course, it goes without saying that the division is eager and willing to work with providers and patients to better understand their gambling-related capabilities and needs. We're looking forward to helping Massachusetts be prepared to handle this important public health concern. So feel free to reach out with any questions. Thank you very much for your attention. We're available to answer a few questions at this point. Should you think of a question after this webinar is over, please don't hesitate to reach out. We'd be happy to see if we can help. And at this point, I'd like to return the mic to Ms. Vanessa Graham, who will provide a reminder about the CEU process and moderate the questions that we've received. Thank you.
Thank you, Dr. LaPlante. So just a reminder here about claiming your CEU credits. To receive them, you must be registered for this webinar and complete the evaluation survey at the end. Additionally, a link to the webinar will be emailed to registered attendees shortly after the webinar concludes. Once you've completed the survey, you will receive your certificate of CEU credits within, it should be 5 business days, via the email address you provided at registration. If you have any issues with the survey, email me directly at vgraham@chaliance.org. Now let's take a look. I think we've got a few questions since we started here, and I'll look at the first one. Is there a link to download this PowerPoint? So yes, we're going to sort of set up all that stuff after the fact, and we can email an update out to everyone that's attended. This next one is, most admitted substance abuse clients report adverse events initially or early in addiction, but continue the behavior. Do gambling disordered individuals say the same?
This is Dr. Sarah Nelson. I don't know of any research directly related to that question among people with gambling disorder. However, our way of understanding addiction, one shorthand, involves the 3 C's of addiction, which are loss of control, craving, and continued use despite adverse consequences. So by that understanding of addiction and by our understanding of gambling disorder looking very similar to other addictions, then you would assume that many people would have that same kind of experience who have gambling disorder.
Thank you, Dr. Nelson. We have time for a few more. This next one is, if objects don't cause addiction, why am I more likely to be addicted to cigarettes than carrots? That's a great question.
Thanks for that question. This is Heather Gray. And I guess I'll just harken back to the slide that I showed near the beginning of my presentation with all the puzzle pieces. And one of the contributors to addiction is the potential, the properties of the potential object of addiction. So that's part of the model. We don't say that the object plays no role in the development of addiction. And some substances or behaviors are more likely to cause that desirable subjective shift that I mentioned that's crucial to developing addiction. So for instance, eating carrots is probably less likely to make you feel good than at least beginning to smoke cigarettes and getting that dopamine hit that nicotine provides. Thank you.
Thank you, Dr. Gray. We have time for a couple more questions. This next one is, what should clinicians do if a person comes in and has two kinds of addiction? Treat both together or one at a time? Another good question.
This is a really great question. And so there are some studies that can provide some recommendations for a provider in this situation. In particular, there's a study by Nancy Petrie and her colleagues where they looked at just the situation where a client with substance use disorder also expresses some problems with his or her gambling. And the question is, can a provider implement a brief intervention for the gambling that goes on top of the existing treatment for substance use disorder? And the answer is that such a brief intervention does seem to help with the gambling that a person is experiencing, and also seems to have some bleed over effects into the substance use disorder. And so their recommendation in that paper, again, this is a study by Nancy Petrie, was that all clients should be offered at least a brief intervention for their secondary expression of addiction, and maybe even something more intense if that's something that they can take on at that point.
Thank you, Dr. Gray. We have time for one more question before we conclude. And this one is, what do you expect to happen if when Encore Boston Harbor opens?
This is Dr. Nelson. I think what we can learn from the research that has been done related to exposure and to new gambling opportunities coming into communities suggests that first, even though many people might worry about a kind of gambling problem epidemic when something like this comes in, that those fears are probably not merited, that what we are more likely to see is most people being able to use this new opportunity without experiencing problems, but that we should be very aware of populations that might already be vulnerable to addiction. So individuals already at risk for substance use problems or experiencing substance use problems, people with mental health issues, communities where individuals have a lot of other risk factors that Dr. Gray reviewed within the syndrome model related to stress and trauma and experiences as well. So those vulnerable populations are the ones that might be particularly at risk when a new gambling opportunity comes in, and where you might want to do the most kind of education, prevention, and intervention efforts.
Thank you, Dr. Nelson. And thank you all for joining us today. If you have any questions or comments about the information you heard today, please email bgram@challiance.org. Goodbye.